Welcome to Healthcare for All Washington's monthly speaker series. I'm Ronnie Shure. I volunteer as president of the board of directors. We are welcoming Jesus Sanchez and from Mar Community Health Center and Kees Kolff, who has joined us and was recruited here at the last minute. We actually started this program with a pre-discussion, which was really exciting to hear Kees and Jesus reminiscing. I think you're tuned in for a really exciting program tonight as we look at community-based clinics, at democratically built healthcare and the impact that can have on our current lives and on our current market-based healthcare system to develop a true healthcare system. Thanks for joining us tonight. You too, just like me, can volunteer for Healthcare for All Washington. Please consider joining one of our committees, our policy or communications or development committee. Alternatively, you could just let us know you're interested in helping with a project or two, or just offer advice. Of course, we look for free advice, which is worth the price. In the chat on our Zoom screen, we ask you, we're going to be posting a link to our website, and you can go to that link and find a donate button. We would appreciate any donations that you could make if you're able, and also a button that says get involved, and that's where you could volunteer to join in our efforts. And every donation, if you are able to make a donation, every donation helps us move closer, further along this pathway to universal health care. It's taking time, and we want to move as quickly as we can, so your donations do help. We've set a goal to raise $250 tonight during this program, so please go into the chat, look at our donation button if you're able, get involved if you have information or a desire to help us. We'd love to have you do that. And check out our website while you're there. It includes our legislative goals, our vision, and our strategies to move along this pathway so that everybody is in and nobody is out for obtaining health care in a true healthcare system. Also, the chat is where we want you to put questions. We will have about a 30-minute presentation from Jesus and Kees, and after they finish, we will process those questions, prioritize them, and then we'll come back on for a discussion. I have muted everyone, so please, if you come in late, mute yourself. Thank you. I'm participating in this Zoom meeting from the land of the Coast Salish people, so please take a minute to acknowledge the peoples and the lands where you are coming from tonight. We acknowledge all of the ancestral homelands and the traditional territories of indigenous peoples who have been here since time immemorial. And we're walking along this pathway to universal health care using the teachings of the leaders of indigenous people. They are walking with us and sharing lessons of life and how to preserve our land. We thank the Coast Salish peoples whose land touches the shared waters of all the tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So tonight, we're going to be digging into democratically based community clinics. In May, we heard from the Secretary of Health from Rhode Island, who leads a national movement for community-based primary clinics. And in June, we heard from a Secretary of Health from Washington State, Bruce Miyahara, who talked about the history of the international community health center services that reach out to Asian and Pacific Islander population of King County. And this month, we're taking another look at at democracy in action as our state's Latino communities stepped up to create CMAR community health centers. Jesus Sanchez worked with CMAR Community Health Centers for way back in the early days and moved on to do a number of other things before moving back in and helping to lead in development of the broad array of services they provide now. He's been a supporter of CMAR for over 35 years. He actually leads some fundraising, which helps with student scholarships, and he serves on the board of directors. So he's still an active employee and board member, and we're so proud to have him here. Jesus took a break from CMAR to fill his real passion for community involvement and leadership. He worked with Governor Spellman and Governor Inslee and King County Executive Tim Hill and worked at the Kingdom, which we all remember, with the Seahawks and the Mariners, and he's worked at Shoreline, and so he's been around the block and has really will bring that information of the role that government can play in our community. Kees Kolff, who also will be speaking with him tonight, is received his MD and his master's in public health from Harvard, and did pediatric training in this area at Seattle Children's and at UW, and he has actually worked with CDC, who's under fire now, so it's a good thing you're not there anymore, and has been a clinical scholar before he actually joined CMAR Community Health Centers. So we have two leaders who have been involved and are going to be able to share that information with their history, and both of them have had broad exposure afterwards. I start to wonder personally what I'm doing, why I'm doing all this volunteer work after I retired from being a pharmacist, but it's envious to see what Jesus and Kees have been doing in their community, serving in public offices. I mentioned what Jesus was doing, but you should know that Kees has been a leader in government over in the Olympic Peninsula and is currently serving on the hospital district board there. He's got his feet wet. So, without further ado, let me introduce and let's spotlight Jesus and Kees to get us started.
Okay, well, thank you, Ron, and thank you for that introduction. Although I have had a mixed bag of I guess career opportunities, but I think it somewhat ties together because whether I was working at CMAR or whether I was working in government, there was always a connection between myself and CMAR with respect to the ability to either open doors to allow access to government opportunities for CMAR or for executives and staff to be able to meet with leadership in Olympia at times, and even with the governors, to talk about the issues and trials that community healthcare go through, what CMAR goes through. And so it's always an important piece. Government does play a role, as we all know, but also we as individuals know that we need to play a role. We, as a Latino, yeah, I had a career to some degree, but it's interesting, unlike, and I may be presumptuous to say this, but I think for me, it's not just waking up every morning and going to work, not just waking up every morning and thinking, what am I going to do today with respect to the job that I have at hand? I wake up in the morning during my career, I've got to get to work, but also who can I help? It's a burden that we have as Latinos to make sure that we don't forget that we have to also have a commitment to try to help our community on a daily basis, beyond just doing a good job in the job that we do. But to be able to think about where can I play a role, whether it's employment opportunities, whether it's accessing a door for communication and dialogue to begin to open an opportunity for growth in healthcare or in employment. So those are the things that happened. But that's just to kind of give you a combination of my public administration and also my involvement in healthcare. But I do want to just digress for just a minute beyond just before I get started with CMAR. I want to talk a little bit about the history with respect to related to my family. And the reason why, because I think it has a connectivity to it, very strong. When I'm not sure, Dr. Kolff, I'm not sure if you obviously are aware of Yakima Valley Farm Workers organization, and many of you are also very well of the Yakima Valley Farm Workers. Well, I grew up in a labor camp. I mean, I was raised in the labor camps at Toppenish, Washington, and the Yakima Golding Farm facilities that were there. And at a time when, back in I think 1953, I was about a 3-year-old. My father died in a farm working accident at that camp, and we were very young. Mom had 9 kids, 9 of us. And the youngest one was 18. The second to the youngest was 17. But the oldest boys. But we had to move out. We had to leave the camp and find someplace else because they needed workers in the camp. So we were allowed to stay for a little while, but we eventually had to leave the camp. And we were able to find an old home, a burned out facility that was a house that was burnt. We thought it was a house. Actually, years later, we find out it was a church that had been converted to a home, and then it caught fire. But what happened then is that we, again, and I go back to the idea of the concept of farm working, because that's what we did. And when we were sick, when we were not doing well from a health perspective, we didn't go to the doctor until we were at death's doorstep, literally, like many people who can't afford healthcare, and more importantly, who don't know how to communicate and maybe not have the same level of language communication. So stayed away as long as we could until we absolutely needed care. And then we went in. And having a toothache was not something that we would go to the dentist for. It was something that we would we would just live with it and do the best we can with it. We'd get a few kind of home remedies that mom would give us, and that would kind of suffice until we got better. But over the years, as we grew up and I went off to college, the Yakima Valley Farm Workers came into play in the late 60s, early 70s. And during that time, the idea of my mom continuing to work. She was 62, 63 at the time. She was picking. I used to pick apples right alongside her in the Yakima Valley. We'd all pick apples together as a family. But when I was off in college and I was coming home, I found that my mom had broken her leg picking apples in Yakima. Now I know this might sound a little strange, but we were all relieved. We were actually kind of happy. And the reason for that is because we knew that she would no longer be able to pick apples. We kept telling her, stop picking apples, Mom. You don't need to do that anymore. We'll take care of you. And so this is the very first time where she decided, okay, we decided to take her to Yakima Valley Farm Workers Clinic for the very first time to get health care. Well, she went there and she received the best of care. There were people that spoke her language there. There was people that were willing to help her and then follow up with her. And she was just amazed. And she got great health care at Yakima Valley Farm Workers Clinic. So much so that she lived to be 103 years old, passed away in 2019, stayed healthy, but she got care. There was a point in time where we thought we were going to lose her when she was about 89. But no, she got good health care, got referred to specialists through the valley, and then after that, got a stent put in at 89, if you can believe it. Oh, it's 90. And most doctors said no, but one doctor said, yes, she wants to live. I can tell it in her eyes, and so we're going to do it. So they did, and she lived another few more years, lived until 103, as I said. But the important thing, I think the message here is that healthcare, community healthcare, a community that spoke her language, a community that spoke to her personally, a community that welcomed her in, that made her feel comfortable, that she began to trust. That, as we say, trust is the first step in getting healthy. If you trust your doctors, if you trust your nurses, and you have a sense of trust, you're going to have a stronger appreciation for what they're providing, and your adherence to taking those drugs are going to be even higher level. And when that happens, you extend the quality of life for an individual. And as you provide healthcare as a clinic, you provide the quality of life for the communities as well. So for me, when I heard about the community clinic starting in the Western Washington, that's when it all began in 1978 with a group of Latino leaders and health activists. And they dreamed and planned to develop a comprehensive healthcare center for Latino communities in Seattle. And with plans, believe it or not, with dreams and plans to develop satellite clinics in rural communities in rural Western Washington. And thinking big, but starting off with an amazingly small little clinic that began in 1978. But today, well, I'm going to stop here for a minute because I'd like Dr. Kolff to really share with us, because he was one of the pioneers with CMAR 1978 period when that began, and his community, the level of staff that we had then. And I'll share with you a little bit about where we are today. But Dr. Kolff, if you could share with us a little bit about your experience.
Well, thank you, Jesus, and I just want to say it's a pleasure seeing you again after all these decades. I think we've seen each other, so this is really a pleasure. I want to reiterate what you said in terms of the Latino community really making an effort to do more than what they need to do or want to do just because their love of community. And that's the most striking thing that I felt when I was hired in 1978, that first year. We had 7 employees. We had bought a small practice, a clinic from a Dr. Sheese, who had been in the community for years, providing health care to this part of Seattle that was really forgotten. It was South Park, right next to an industrial area. And I think most people just really assumed that the people would eventually die, they'd give up, they'd leave, and their houses could be abandoned, and then industry could move in. So Dr. Sheese was providing health care. And when we bought the clinic, 2 of his employees stayed on. Jerry Wheaton, who was the nurse, and Jerry Deuce, who was the lab tech, and even had an old X-ray machine. I mean, she was phenomenal. She could do a little bit of everything. And we hired 1 receptionist, and there were 2 physicians, Dr. John Morris and myself, and then Mary Bartolo and Rogelio Riojas. So we had 7 employees in the beginning, and I was just struck by how dedicated this board was to building up not only the services for the Hispanic population, but for everybody who came through the door. I mean, most of our patients during those first years were the elderly white folks from this community that had been abandoned by the city, and they were just so delighted to be able to get care, to have a clinic where they had a sliding fee scale. I mean, these people were just blown away by the generosity of this newly forming clinic. And I had learned Spanish while trying to cobble together healthcare for a number of Chilean refugees at the time. I was finishing up a fellowship at the University of Washington. And so I was looking for a clinic where I could bring Spanish-speaking patients. And fortunately, they were looking for a Spanish-speaking physician. So it was a perfect match. And in the beginning, we just had community health center monies, not for migrants. They had been able to show that the Seattle area was underrepresented by the Latinos there were underrepresented by the healthcare system. So they got a community center grant. And it's only a number of years later that we were able to get into what I think was really an even more heartfelt movement, which was to start migrant health center clinics. The first one was up in Marysville, then Mount Vernon, then Bellingham. And that was with a different pocket of money. But it was just amazing because we would come in and provide the kind of care that Jesus is describing that was possible on the other side of the mountains. And so we did what we could. with these migrants, families, their farms, and their housing. And I won't begin to get into everything else we did because I don't want to steal Jesus's thunder, but no, it was remarkable.
No, and it was. Thank you for that. And certainly like to please chime in to add more to it as we go through this conversation, because it is important to let everyone know and for everyone to understand really the history of these amazing challenges and the history of these amazing, I think, growth that we've had. CMAR, again, as we said, began in 78. And this was under the leadership of Rogelio Riojas, who is still with CMAR today after 45, 46 years. He has never left CMAR. That's his passion, that's his mission, and it's his commitment to the community has been strong to this day, and it hasn't changed. And his mission has always been is to serve the low income, to serve the underserved and the underinsured as well, or the uninsured as well. And in particularly, though, for the need for the Latino communities under that level of healthcare. And his view has always been that this has got to be done. We cannot shy away. We have to be able to do that. And whoever comes through those doors, it does not matter. Whoever comes through those doors will be served, and with or without ability to pay. We just believe that we have to do that. And we want to do that. And that's Rogelio's mission and value that he has always kept as a CMAR executive CEO, and has built an amazing organization to this day. As Dr. Kolff has indicated a minute ago, the number of employees that we had back then. Today, you see CMAR with nearly almost 3,000 employees working at CMAR. And the level of services from, as you know, dental, obstetrics, minor substance abuse, radiology, behavioral health, and even and obviously primary care and migrant primary care that we have, dental, substance abuse. Those things are all part of the CMAR levels of services. We have many more. And we serve now in 13 counties throughout the state of Washington, throughout the Western Washington portion of the state. But in with that, we knew that healthcare with respect to medical care that we provide wasn't enough. We also knew that we have to try to look for, and as much as we could, look at affordable housing. It's one of the key principles and needs for extending and improving the quality of life for communities. And from that, basically, CMAR began and developed a construction company. And we built we hired our own architect, who's now on full-time. He's busy throughout the entire year, either remodeling old buildings, designing new medical dental facilities, and building with our own construction company. We trained our staff, employees. We have our own contractor who will come in, and they will build. The beauty about construction there is that when we look at the construction, as you all know, when you're constructing, there's always the contractor's obviously revenue in terms of the contractor's total cost of the business to do business. Obviously, they're going to charge a 25% return on investment that they're going to get maybe based on what they're building. So contractor salaries are all built in. But what we do is when we build, we don't take those contractor salaries. We don't take a salary from those. What we do is we turn those salaries and those revenues, and we put them back into the affordable housing units. And what that means is that we're able to put in stones, good carpeting, solid flooring, quality kitchens of the highest caliber, instead of plywood and these kinds of things that are very soft tissue that can deteriorate very quickly, or countertops they're very wooden countertops. We built with quartz and granite countertops. Everything is done in a high quality. We want the people who do come and stay in our facilities to feel comfortable and to be proud of where they live, and that it's a beautiful facility. It's not a project. It's their home, and we want them to feel comfortable there. But in addition to that, we also will add a medical and dental facility and behavioral health facility on site along with that housing project. We have that in Vancouver. We have that in Des Moines. We have that here in South Park. And we're building one right now, 6-story facility with a medical, dental, and healthcare facilities right in South Park, our old building, Dr. Kolff, as you know. That's been a 3-year experience. Now that old building that you remember being in will be gone. Right now they're in the construction stages, and so we've had a few ups and downs in terms of delays because of the city permitting process. As you know, permitting has never been an easy process. In fact, I talked to the mayor, one mayor, or our last mayor, Bruce, about the fact that we need to have a expedited process for affordable housing because it has a public benefit. And this is not a for-profit construction development project that's going to go in and develop a profit for the owners. This is a construction project developed for communities that can move in, have affordable housing, be able to afford to live there. But it's a public benefit. And that public benefit should have an expedited review because that means that we'll be able to bring in people into these homes much sooner than later. But we got delayed for quite some time.
Jesus, were you going to also mention housing for migrant and seasonal farm workers? Because that was a big issue early on, was the housing for them, and which was often problematic.
Yeah, if you recall back under Governor Lowry's days, if you recall that period, and even under Governor Locke, we had issues, really strong issues with housing because people were living along the river banks, little tents, and farmers, agribusiness knew that's what they were. And we tried to get a support from the governor's office and funding for housing, but it kept getting denied. It kept getting rejected. So we had to put pressure at the state level with the governor's office to finally acknowledge that housing had to be an integral part of providing for farm working communities, or agribusiness, as I call it, for these communities, for migrant families who come, and for local farm workers who are working in that community to have housing. So we fought on the side, beyond the healthcare side, we also fought for housing initially. And we were able to address, for the most part, a good chunk of that for the state, actually for Eastern Washington and Western Washington both. And that continues today. We still will battle for those things. But they're an integral part of healthcare. Affordable housing is an integral part. The last thing we want to do is provide medical care, provide prescriptions, and have someone try to improve their quality of life by taking medications in a car, sleeping in a car, in a tent, and trying to get better. That's just not, it's just a self-defeating situation. So we look as much as we can to build. And it is a costly endeavor. We recognize it is, but at least if we can provide some dent in the housing community, we're going to do that. And that's been one of CMAR's. So we have our own construction company. We also built our own radio station. We have our own radio station here at CMAR that now we're able to provide information on healthcare. COVID was a huge impact to us, all of us, as we know. And that radio station played an integral part in getting the community informed about COVID, the importance of taking your COVID shots. And the information that we were getting from the CDC provided that information on the radio station in Spanish and English so that we could be able to get the trust and confidence from the community to come in and be able to get their vaccinations. And we had lined. Go ahead.
You might want to use a different source than the CDC during the next.
Yeah, that's for sure. That's not going to be used anymore. That source is kind of dried out. But the important thing is then we were able to get some direction. But mostly important was that we worked with the governor's office as well to really look at how we can work together as a team. And we opened our doors at 6 a.m. every day. And we had lineup of people coming in from all walks of life. And we had, as I said earlier, we've had about 120 plus languages that we speak. We have interpreters at all of our clinics. And COVID shots and support, vaccinations were one of the major things that we were providing. In fact, I think we're second in the state of total number of vaccinations that we were able to provide statewide, or at least in Western Washington. So it was really big, over 600,000 or so vaccinations. We just did quite a bit. But that's CMAR. Again, we were able to use that radio station as one of our key pieces for making sure that we're able to reach out. We also developed pharmacies. We decided that every clinic should have a pharmacy. To the extent that we can build pharmacies, we built pharmacies at most of our clinics. Right now we have about, I think, 17 to 22 pharmacies right now. and still building, still looking at improving. We've added technology to it so that we can order the prescription right from the room, and the machine systems will pull out the, I forgot the name of the company that we purchased for these systems, but they basically produce the prescriptions right off the spot, so the patient walks out with their prescriptions and not have to come back again. And believe me, when you have to come back and take a bus, if you don't have a car, it's not an easy, trip for them. So why let them go out the door without their prescription? So it's best to make sure that we're able to get to everyone. The other part that I want to share about our communities is as we're talking about today, and I think it's very important that Dr. Kolff has talked about, is the history, is that it is important for us to understand all this, why we're here tonight and talking about this case. Because if we don't understand our history, as we all know, it's practically impossible to understand how to build a vision for the future, or what is it that we need to move forward towards if we don't understand how we got here. And today, as you know, and you might have heard, I don't know, Dr. Kolff, if you heard, maybe you can share a little bit about that. But what we're seeing today in this administration, and what's happening in many of our partners in the healthcare. Swedish, for example, reducing their layoff positions by 300 people, or 250 million in losses that they're taking, and then the lowering the cap of patient care costs, which means serving patients, which is lower than at a greater cost than the reimbursement rate we get for Medicare or Medicaid.
Mm-hmm.
And again, due to federal cuts, budget cuts. I mean, budget cuts, for example, is 27? Maybe I'm missing, I forgot what it was, but it's several $1 million that the state is going to be short in 2026. And that's what they've got to find, a real shortfall. We're relying as a health organization to try to make sure that we're able to receive the level of support from the state level.
Yeah, maybe I could ask you,
Yeah.
Your Medicaid population, because
Mm-hmm.
I'm currently on the board of Jefferson Healthcare, which is a critical access public hospital district here in Jefferson County. And our estimate is that if the Medicaid cuts go through as planned, that up to 3,000 of the people living in Jefferson County, 10% of the people in Jefferson County, will suddenly be without Medicaid. And we're committed to serving them as well. So we're bracing ourselves for an increase in the charity care that we have to give. Yeah, I mean, we have to keep our doors open just like you do, because you're committed to that. So what is your situation with regards to Medicaid and the population?
Well, it's the same. I think, for us, for our situation is basically with a cap, it's costing us, the reimbursement rate is so much lower than the actual cost of providing the care for patients. And when that happens, we're taking, $25, $30 loss for every patient that comes through the doors, and probably even greater. But the point is that are we going to then limit that? And the answer is no. We're going to continue to serve. We are going to continue to try to be able to generate revenues from other sources that we can. We're not going to stop from just simply, fold up our hands and say, well, we can only serve who we can serve, and we're going to have to cut back. No, I think our goal is to continue to grow and continue to keep pushing. And we're going to continue to serve our community. And whether they come through the doors, whether they have the ability to pay or not to pay, as we've said before, our mission stands very strong. We're committed to serving everyone that comes through those doors, whether they're insured or underinsured, or under the level that they just cannot afford anything. But our goal is to not drop our level of service.
Yeah, I noticed in the question there's a question about or was a question about training staff for the future, and I might mention that early on, CMAR developed a residency program to be able to train family physicians in the kind of care that's provided in a community health center, and that's been a very successful way of getting additional physicians and particularly finding those who want to work with the traditionally underserved community. So that's
Yes, absolutely right. We not only at the residency level, but also at the medical assistance level. We've developed our own program for training our own medical assistants. We're now in the early stages of completing a dental school in Tacoma. We've been working on that building and construction and working with Washington State and others. We're building basically a dental facility where we can train dentists. And our goal is to continue to grow our own, so to speak, as we continue to move in that direction. And the thing is that when we look at this opportunity for us, one of the things that we become also is an opportunity for other facilities to hire out from our own training facilities, which is an opportunity, but everybody benefits, from our schools. But you're right, you have to continue to grow our own. And we see it. In fact, some of our revenues that we picked up from generating from our fundraising efforts that we've made, we've been able to support young men and women, Latinas that have gone on to become doctors and come back to work at CMAR, or have gone back or gone over to their own communities like Quincy, Washington, and provided medical care there as a doctor or as a dentist. We've had dental folks come back and become dentists. So it's really heartening to see that happen when they do want to come back and serve in the community, or they want to serve in the community where they grew up.
Yeah.
And it's a real source of pride for them.
Do you, at Jefferson Healthcare, we have our own ACO, Accountable Care Organization, that we have worked out, and where we take care of somewhere around 9,000 people who are on Medicare, not a Medicare managed program, but on the traditional Medicare. And for us, that's been a very important way in which we get a little better control of our Medicare population. And hopefully we'll be able to, the savings that we get by treating these patients, these people as whole people, and preventing illness as well as treating them, hopefully we can then feed back in to provide more care, whether it's home health nurses that go out and work with people who have diabetes to keep them out of the ER or whatever. And so I'm wondering if you could mention a little bit about that, because you've also gotten involved in managed care of one sort or another, have you not?
Yeah, yes, we have. I mean, I think very similar to yours. I think I maybe at a little bit higher level, total number of patients that are served by it. But it's basically, it's an identical approach that we've had as well at CMAR. And it continues to be that way. We do have savings that come in, and we're able to inject those savings into where we are obviously showing losses. One of the other things, if I can just digress for a minute, is I'm not sure are you familiar with the 340B program?
Yes. Yeah.
Okay. 340B program is one of the most important pieces that I have seen for CMAR and for any organization in healthcare, obviously, because 340B program is designed very simple, stated in the federal regulations, that 340B is designed to generate revenue within the clinic to be able to support, provide funding support for medical clinics to grow and serve in the community, basically, whether it's for providing salaries for doctors, whether it's providing medical equipment for training, and it basically leaves it wide open so that it allows the clinics to grow and expand in the level of services that they provide. And how does that work? It's very simple. There are a certain level of medications that are been set up with an agreement with the federal folks back east, where the drugs we are able to purchase drugs at a lower cost, where it's been placed with certain insurance companies at a certain ceiling of the cost of that drug. And we can buy, say, for example, a $1,000 drug that someone would need to pay on the normal market. And that $1,000 drug that we purchase it at, we could purchase it at, for example, at $90 to $100. We turn around and sell that drug to the patient for for the same price plus a $10 dispensing fee. Now, with that dispensing fee, we then go ahead and submit, and this is again more for insured patients, really. For all those insured patients, we go ahead and submit that cost. And the insurance company does pay the market rate for that drug for that patient. So we will have a profit of $900 for that drug, but the patient only pays $100, and we then get reimbursed at the full market rate. Well, that $900 helps us pay for those patients who are below the cap, where we are actually losing money for those patients. That helps offset those costs. That also helps us offset or improve our ability to bring in the state-of-the-art equipment, both in radiology, for example, or dental work, dental practice. It's just a lot of equipment that we need that's very expensive, that we're able to purchase, and we do. And we've expanded a lot of our programs because of the 340B program, and expanded our level of services because of that same 340B program. Now, it is in jeopardy in this administration. It's in serious jeopardy. In fact, I've seen a couple commercials already starting to be a little bit negative about specifically the 340B program, which I've never seen before. And it came out as a 340B issue. It's insurance companies who don't want to get engaged with that. They want to be able to charge what they charge and not necessarily be able to lower those drugs. They're trying to avoid lowering the drugs, and they've been fighting that for so many years. So yeah, we look at opportunities, just as you mentioned, where we can generate revenue, where we can then move those dollars into those places where we are taking losses, and it allows us to keep an ability to keep our doors open and be able to provide service for everyone that comes to our doors, no matter what level of financial need they may be in. So it just continues, and it's something that we do. Today, as I said, we're in 13 counties and growing. And how we grow basically is the cities or counties will call on us. And we'll call CMAR and says, would you be interested in coming into our area? We don't go looking for them. We actually get calls. We used to maybe go out and do our own research. But today we are actually getting calls. We're actually building another clinic, by the way, brand new clinic, should be completed this year in Vashon. So Vashon is going to have a medical clinic in Vashon, hopefully by the end of this year. So that's really cool. We just picked up a new health clinic in Everett. Yeah, I think we now have 2 medical clinics in Everett that we didn't have before. So we just opened a new one along Highway 99. So it's growing. Again, we just opened up another clinic. But it's one of those things that I think for us, we're going to continue to grow. But I think tonight's conversation is really asking ourselves a question: why? Why are we talking about healthcare tonight? What is the issue? And the issue is really, very important for us right now in this period of time. We have an administration that's looking at this programs. It's kind of a slash and burn kind of approach, and there will be a lot of what we consider collateral damage to a lot of communities that's going to happen if we don't stand together. And I think talking about tonight and healthcare gives us a sense of what it is that we need to do. Because when we take a look I look at it from this generation, is that this is a generational fight. This is not, or a generational struggle, I guess I should say. We've made tremendous gains, Dr. Kolff, as you know. We've made tremendous gains in community care. But those gains are now in jeopardy. Now, I know that, in my view, we have a short-term 4 years of this administration. So I look at it as it's a temporal situation we're in, and we have to try to survive for the next 4 years. Our goal is to not lose one of the gains that we have had so far. But having said that, we also have what I believe is a generational, because it's all temporal. Like we are in life, we're all temporal. But we have to leave a sense of a vision and direction for the next generation to continue the battle and the struggle to make sure that our communities statewide finally achieve what I consider a right to healthcare. And as you all agree that health is a human right, and that needs to happen at some point in the next years to come. And I think it has to come sooner than later.
And I think there are 2 parts to that, Jesus. One is we need to continue to resist and to deal with the issues, the cuts, and the misinformation and the changes at the federal level. But at the same time, I think we need to keep our eye on the long-term goal. And I noticed that there are a couple of people from Physicians for a National Health Plan who are listening in on this conversation. And we need to continue to look for a way to solve the general healthcare lack of system in this country. Because as long as it's fragmented, as long as the people in Washington, D.C., who have their own national health plan, thank you very much, as long as all of these elected officials, they're not motivated to give the same benefits to the rest of the people in this country. So unless we can do that, then we are at the whims of a shift in administration. So we've got to continue to focus on the long-term healthcare for all, and whether it's national physicians for a national health plan, whatever the system is, but we got to get the middle people out of it. Got to get the for-profit, managed care folks, industry folks, insurance folks. We got to get them out, get the middle people out.
Yeah. There's a question. Go ahead,
You all
Ronnie.
have been answering some questions that are in the chat. So let's take a few minutes to pull those questions together, and we'll bring up someone to help lead that discussion along with the two of you. So Case and Jesus, don't go anywhere, but I'm going to take the spotlight. Ron is going to take the spotlight off of you for a moment. And I'd like to introduce Peter Lucas, who is another member of our board of directors. Peter is a Bainbridge Island member who's volunteered to be treasurer of all things. So, Peter, do you want to step up and share that information or the way to get into our website to get involved, to make donations?
Well, sure. Well, that was a very inspiring discussion, very informative. I really enjoyed hearing about the history of CMAR and your commitment to communities, and then your holistic approach, addressing socioeconomic determinants of health with the housing thing you're doing. That's just fantastic. And we at Healthcare for All want everybody covered. We want a universal system too. And as Dr. Kolff was saying, we want to get the middle people out of the system, all the rent seekers and the money skimmers out of the system. So, as you know, Physicians for National Health Program is working nationally. We're in our organization. We're working on a state level in alliance with other states. So one way or another, we'd like to see that happen. And we'd like all of you who are on the call to support us. And that could entail volunteering for us. That could entail certainly donations. That's what I'm here for. I know there are quite a few new folks on this webinar tonight. So I just really encourage you all to go to our website, sign up, register. There's a link. I think it says "Get Involved." It's up at the top. You can see what the volunteer opportunities are. And we've been posting the donate link in the chat all evening. So please go to that. We especially encourage recurring donations. Those are really, really helpful. And where your money goes, it goes to support our very capable lobbyist who works for us year round and is very active in Olympia during the legislative session. We have a communications specialist who does all kinds of things. Our social media gets the word out, but none of this is free, and we need funding to cover all this. So, to those of you who do contribute regularly and have contributed, we certainly thank you, and we appreciate your continuing support. And those of you who haven't contributed, please do. Just go to the link and make a contribution or recurring contributions. And thank you all for contributing and for being on the call tonight.
Thank you.
And thank you, Peter. Thank you. So let me bring up John Sobeck, who's another member of our board. Dr. Sobeck is an OBGYN who has stepped out to volunteer with us, leading our or is the vice president of our board right now. And so thanks for joining us, John. And if we could bring back Jesus and Kees, I see some questions that we might actually, I don't know if you're prepared to join us, Nick, but we might bring you into the discussion too. Nick Ramirez might have something to add about 340B questions that I'm starting to see. What are your thoughts, Nick?
I'm here and I'm ready to help where I can.
Hey, Nick.
Hi,
Yeah, and
Jesus.
Ronnie,
Hi,
I
Dr.
put a
Kolff.
link to the um, uh, 348B program description. I think it's a pretty complicated thing. It may take up a little bit too much time.
Yeah, I think what I would want to say, the question was, is there something legal behind it? Yes, the federal government decided that this was an important thing to do. And so there is a law that says that defines how the 340B program works. Pharmaceutical companies and insurance companies, of course, are not happy with it, but too bad. The Congress at the time figured that they were making plenty of money off of pharmaceuticals, and so they decided that this was a good idea. And the whole goal was ostensibly to make pharmaceuticals less costly for patients. But as Jesus said, there are no restrictions as to how you use it at all. And so it is less expensive for the patient, but the money doesn't have to go back to provide anything in particular other than what the healthcare entity decides is the most important thing for their population of patients. To keep them healthy is really the goal. Provide care and keep them healthy.
And
That's
when I was
great.
on the payer side, the commercial payer side, there was always a question: should an organization as big as Providence be profiting off the 340B program? So that small not-for-profit clinics probably need it, big Providences maybe not.
Well, I think when you look at it, the if I can maybe put it this way, financially, is that rather than government providing taxpayer money to lower the cost and buying those drugs to lower the cost, this allows corporations to be have to lower their cost to allow us a profit on the side. But it's not a tax dollar. It is a non-tax dollar. It's private dollar. So it's really lessens the burden and responsibility on federal government taxes to use for lowering the cost of drugs. And it opens the opportunity for us to create a profit. Now, large or small, if they're providing healthcare, if they're providing medications at a much lower rate at 80 to 90% of lower cost of that drug, whether it's a large organization or small organization, the patient is benefiting from it. But if they're using it for profit for humongous salaries, that's a different matter. But I think when you look at the growth that we're seeing in communities, when we continue to expand clinics, which is what the 340B has allowed us to do, is to expand more clinics, to buy more equipment, to pay our providers a salary that they deserve, to pay our nurses, to pay our medical assistants, all of these employees that we need to have specialized care that they are able to provide with these amazing skills. We need to make sure that we can keep them and have them, because it's a competitive market out there. And so we have to make sure that we're paying everyone a good wage to the extent that we can. And that allows us for it. And it allows us, quite frankly, hopefully as this continues, to weather the storm that we're going in now, because it does allow us to continue to generate revenue to support the losses we're going to see.
And if there's anybody
Nick,
if there's anybody out there who has debt from medical training, remember that there are many FQHCs, many places where you can actually get debt relief from your debts by working in an area that is underserved.
Yeah, that's true. Nick, did you have any thoughts on that?
Yeah, and I would just say that the 340B program is under attack. Since 2020, we're seeing manufacturer restrictions that create additional barriers for specific medications, for how we contract, how we're able to obtain the 340B funds. And then many of you have probably heard about the rebate pilot program, that has been instituted by CMS. But that adds administrative burden, it adds costs, it makes it way harder for us to be able to tap into these funds. And it's something that we need to really come together and combat against. These types of things are compounding, that with the Medicaid cuts, with the reporting requirements, those things are going to take its toll on FQHCs like CMAR, but also in the I would just advocate for us all to identify what those models look like and how it impacts organizations like us.
Thanks, Nick. And I think going forward, you're right. We're under attack on all fronts, not just 340B, but it's on all levels of service, including taxpayer dollars, and then regulating the level of dollars, how we can spend them based on government's new changes in policy in terms of what levels and who we can serve and who we should not and cannot be serving, and all these things. Our view in healthcare is we're going to serve anyone that walks through the door. That's just our policy. Now, the thing is, I think I saw a question from David. Was it David Loud? I think he was asking, what are some of the things that CMAR is looking at in 2026? Did you see that question? I'm not sure.
He actually said 2027, but 2026 is good too.
I meant 2026.
Hi, David. How are you?
Hi, Jesus.
Yeah, I miss you. Have missed seeing you guys.
Mutual.
Well, I probably turned it to Nick again, but I can share a couple thoughts. In fact, some of the things that CMAR is looking, because I sit on the board. Obviously, I'm on the board of CMAR's board of directors. But CMAR view is basically a several number of steps. Number one, we are going to continue to stay in touch and communicate with our national folks, national leadership. Those that are responsive to our needs are basically our representatives, both in the congressional and the Senate side. We continue to do heavy lobbying there and to talk about the importance and the need. We share with a lot of our information in terms of what we're seeing and what the costs are, but also what the impact is negatively to communities. We're also talking and setting conversations with governor's office as well as the state legislature. It's important that the legislature truly understands what we're trying to do here, and that they look at funding and recognizing that we're going to be competing in 2026, 27. We'll be competing for funds with the state. I mean, against a curtain of the background curtain here of several millions of dollars of shortfall that the state is in coming in 2026, and they'll have to look for how they do that without raising taxes, I guess is what I'm hearing from Governor Ferguson. But then again, we go right back to the other level, and that's the level of the city and county levels, to see what the city and the counties can get more actively engaged and more involved at the funding level. We haven't seen a strong city and county engagement, I think, as strong as it needs to be or could be. We've seen, of course, state and federal, and we rely on that. But we're also planning to save our money as much as we can and hold on to maybe buy a little bit less equipment and make sure that we're able to pay for our patient care that we provide. So it's just basically being more frugal about it, but it will allow us to continue. We see that we're able. We believe that we can we'll be strong in 2026, but 27 will be a challenge for us. I don't know, Nick, did you want to share?
So it's 8 o'clock. Thank you all so much for joining us, leading us in conversation. There is not an easy step to solve all of our problems, but this is such a great example of how we're going to get there. Democratically based, community-based organizations that meet the needs of the social determinants of our health, of the political determinants of our health. We started this conversation, I guess, before we actually went live, about what is the role of government. It can do some things, it can't do everything. We have to be there to make it happen. And this is just such a powerful example. So thanks, Jesus and Kees. we invited you to come along and
Let
pay some role, but Jesus pulled you into a leadership role. Thank you for being here, Case.
Let me challenge the participants. I'm almost finished filling out a $100 donation to your organization. So I'm encouraging everybody who's listening. That's the way you gotta do it.
Okay.
Thank you so much. And
Thank you, guys, and thank you, everyone. Thanks, Nick,
and thank you, Nick
Dr.
and
Case.
Jesus and Case, and also all the volunteers that make this happen. Thank you so much, and thank you for showing up. It makes it so worthwhile when you ask these questions, when you take the steps that you're doing. So thank you.
You're very welcome.
Thanks.
Thank you again. Good to see everyone. And Dr. Kolff, it's always a pleasure to see you. Really was joyful
We
to
gotta
see
get
you.
together sometime.
Okay, we will. Take care of yourself. Take care of everyone, and have a Merry Christmas and enjoy the holidays with family.
All right.
Adios.
Thank you.